Tonight we're going to talk about traumatic arrest, cardiac arrest involving the trauma patient. Hopefully you guys were able to see the Facebook load of your test review as well as your lecture for Tuesday night, which is on Canvas as we speak. Your classmate Daniel helped us significantly with this. So, talk about traumatic arrest. Traumatic arrest does not differ much from regular cardiac arrest with ACLS care, except for the mechanism of the arrest is from trauma versus medical causes. Remember from the past lecture that people can have trauma as a direct result of a medical condition, i.e. a medical condition, hypoglycemia causing unconsciousness to cause you to drive your car into a house or something like that. But when people arrest from trauma, they normally arrest from a couple different things. One of them is loss of volume through hemorrhage. Another one is through tension and pneumothoraces, or tension pneumothorax. They have a collapsed lung that causes cardiovascular compromise. And the third being airway obstruction, are the three big ones that cause people to arrest. One thing to keep in mind, as we've talked about in the past, is that solid organs will always, when they're lacerated, will always bleed. Hollow organs will always spill their contents. Therefore, people who have insults to solid organs tend to become very hypovolemic and really shocky real quick, whereas people with solid organ rupture, they tend to spill their contents where they become septic and die from infection as a result. Okay. So the objective of this chapter, and this chapter is not very long, and I'm using these slides like I talked about in the last group, just because it kind of breaks up the chapter in chunks, and it's the same material. But traumatic cardiopulmonary arrest, much of what we do in the field does not have a whole lot of bearing on traumatic arrest. Traumatic arrest, trauma tends to be what they call quote-unquote surgeon's disease, meaning that if you don't have the right people at bedside that could do the invasive surgery, sew up that hole in the heart, and do all types of things like that, the patient ultimately will not be viable. So we're going to identify patients in traumatic cardiopulmonary arrest who should withhold resuscitation from, patient that, there's just no way they could survive the event. And we'll talk about ones that really optimally should be worked at all costs. Unsalvageable patient. Very rare do people survive from cardiac arrest. And if you look at cardiac arrest, especially involving a traumatic cardiopulmonary arrest, if you look at it, it's a bigger risk to the rescuers than it is the actual person. Someone that has a traumatic arrest that requires transportation. You're transporting lights and sirens. You're transporting, there's all types of risks associated with doing that. But the thing that's important is some cases definitely have correctable things which you can identify, such as a tension pneumothorax with a needle thoracentesis. You could take someone and resuscitate on arrest pretty quickly just by doing a needle thoracentesis or a needle chest decompression. But a lot of times when people arrest from traumatic causes, unless you're right there to fix it, survival is pretty rare. Okay. Resuscitation, temp transport, expose public and EMS to risk. You really shouldn't attempt to work a traumatic arrest unless there's a chance of patient survival. So you've done assessment on those patients. You find that a patient has a condition that's conducive with life, and and there's something immediately you can do to fix that, or you're within close proximity of a trauma center where you can get the patient somewhere that could do the much needed procedure there. Always need to be aware of your local protocols, your local standing medical orders, and so forth. Pre-hospital trauma arrest guidelines are pretty easy. These are the different guidelines: resuscitation withheld, resuscitation initiated, or resuscitation terminated. One thing that we recommend generally is if you're going to start working a traumatic arrest, on scene, then you work it on scene, and if you need to terminate efforts, you can contact medical control. If you move the traumatic arrest to your ambulance and you're still performing a resuscitative effort, then that patient should be transported to hospital. It's a general good rule of thumb not to call someone dead in the back of your ambulance, because at that point in time, once someone goes from living to dead, legally you can't transport that body until the coroner comes. And if you're in a rural area, that could tie up a much needed resource, housing a body until the coroner can get there. So generally, you want to look at that. Also, when we look at traumatic arrest, we also want to look at triage. Triage involves doing the most good for the most people with the most viable coming first. If you have multiple patients and you only have an ambulance or two and don't have enough resources to manage both of them, then a person who's pulseless and apneic or a person with agonal respirations who's well on their way to arrest becomes a black tag category. Triage is evolutionary, so if you do get additional resources, you can always up triage somebody. So, but if you always want to take care of the most viable first. Resuscitation withheld. If someone is not breathing, no pulse, no cardiac activity, um, blunt arrest on EMS or blunt trauma, excuse me, when you get there, penetrating trauma, obvious signs of death that go along with any cardiac arrest. So their pupils don't respond. Um, there's no pulse. There's no lung sounds, anything like that. They have injuries incompatible with life. Obviously, the one we talk about is that someone is decapitated. It doesn't matter what someone's heart rate is, and really, I don't know why anybody would put a patient on a heart monitor when their head is separated from their body. But injuries incompatible with life. One could be a person who has severed both extremities and all their blood volume is on the pavement. There's not much you're going to be able to do for that patient. Another one being a penetrating wound through the heart, where your patient's asystole can get there. Significant downtime, just like with a medical arrest, depend lividity, that's where their blood pools to the lowest points of their body. Rigor mortis, where the body becomes stiffened, their pupils become fixed and dilated. Things like that. These are ones we really want to withhold cardiac arrest efforts from. They tie up a lot of resources for a less than 1% chance of survival. Guidelines for terminating resuscitation. If you have blunt trauma, no breathing, no pulse, depending on the rhythm, we always treat according to like ACLS as well. So if the patient's VFib, ventricular fibrillation is always treated with defibrillation. Ventricular tachycardia without pulse is always treated with defibrillation. So we want to look at the whole patient presentation. What type of trauma does this person undergo? Does this person pulseless and apneic from head trauma and there's brain exposed? That is a mortal wound. If cardiac arrest the effort has been started, and you want to always assess your patient. So first responders get there and they start working cardiac arrest. Get there and do your assessment. Is the airway open and patent? Is their breathing adequate? If they're in cardiac arrest, obviously they're not going to be breathing. But when you ventilate them, do you have good lung sounds bilaterally? Do you have things like that? What's your transport time? Do you transport, is it 10 minutes? Is it an hour? So these are things we want to look at, whether we do this or not. Once cardiac arrest has been started, you should always contact medical control prior to termination of efforts, unless, there's obviously late signs of death or a mortal wound, something like a decapitation. Special consideration has always been given to victims of near drowning, especially cold water drowning, lightning strike, and hypothermia. Hypothermia slows the metabolic rate down to where, patients could take on a state which looks much like a cardiopulmonary arrest. And they have a pretty high rate of resuscitation upon warming, and they tend to be resuscitated easier. Lightning strikes, our bodies are made of water and heart runs off electricity. So when someone gets hit by lightning or any other electric shock, they should always get cardiac monitored and treat all lethal rhythms such as VFib, VTAC. Any trauma patient who's been electrocuted or hit by lightning, electrocuted that way, every one of those patients receive cardiac monitoring and transport to hospital. You should never get a refusal. One would hope you wouldn't get a refusal off someone struck by lightning, but you never do know. So traumatic arrest, just like anything, circulation, airway, breathing, treat the underlying cause. So what caused this person? What came first, a chicken or egg? Did this person go into cardiac arrest, then have a traumatic event? Is a traumatic event what caused the cardiac arrest? Prolonged hypoxemia or hypoxia is the most common issue. So we have airway issues. So is there airway obstruction? Is there airway not open? Sometimes just simple opening the airway and positioning the patient could fix some problems. You always use the modified jaw thrust to open airway on trauma patients, because traumatic arrest, we always have to assume that there is cervical damage associated with that. Breathing problems. Is this person breathing? Is their breathing symmetrical, meaning chest rise and fall equally on both sides of the body? Is the patient having adequate tidal volume? Is the person belly breathing? When you listen to lung sounds, is their lung sounds more prominent on one side than the other when you ventilate them? So, do they have things like jugular venous distension, indicative of tension pneumothorax? Remember, tension pneumothorax, we look at things like, jugular venous distension, decreased cardiac output, hard to bag, absent lung sounds on affected side. All these things are things we suspect, and you should not withhold doing a needle decompression. It is the protocol in the Good Samaritan system on all traumatic arrests involving chest trauma that prior to considering termination of effort, you perform a needle decompression on both sides of the chest. Just because that is one procedure that can reverse a cardiopulmonary arrest, and just as a one last ditch effort to go ahead and trying to do that if that is the root cause. Another thing that can be reversed is cardiac tamponade, where the pericardial sac fills with blood and squeezes the heart kind of into submission. The treatment for that is a needle thoracentesis, where they drain that blood off of the heart. Doing a needle thoracentesis or a pericardiocentesis, same thing, involves the hospital. Pre-hospital folks generally do not do those. There are some expanded scope areas where the procedure is done. However, generally that's not something that's done these days. Other causes of traumatic arrest, airway obstruction is a big one. Ineffective breathing will cause it. CO2 accumulation. So does this person have adequate tidal volume? Is this person in shock? Remember, shock is a widespread state of inadequate tissue perfusion. So a hypoxic state that's a systemic in nature will cause a buildup of CO2. Your patients will become acidotic. Your patients will do poorly if you don't correct the oxygen perfusion mismatch. So, meaning by VQ or ventilation perfusion mismatch means you could push an adequate amount of air or oxygen into these people, but if they don't have enough circulating blood volume with oxygen carrying capacity, that oxygen won't be taken nowhere. And with that said, CO2 won't have anywhere to be offloaded and be rid of. So generally, when performing a traumatic arrest, whatever advanced airway management you do, whether it be intratracheal intubation or IGEL placement, use of capnography is very important for determining level of perfusion. Remember, pulse oximetry is a measure of oxygenation. End-tidal CO2 is a measurement of perfusion, how well your body utilizes oxygen. Airway problems, foreign body airway obstruction, tongue prolapse, swelling. Tongue prolapse means the tongue is hanging out. Do they have swelling of their airways? Is there tracheal damage? Do they have tracheal deviation, which is associated a lot of times with tension pneumothorax? However, it is a late sign. Hemorrhage into the airways. Does this person have an airway full of blood from a hemothorax? Hemothoraxes do happen where instead of the chest cavity filling with air, in the pleural space it fills with blood. Misplaced advanced airway. Once you have an advanced airway placed, it's not set it and forget it. You need to listen to lung sounds. Every time the patient is moving, you verify lung sounds. And all advanced airways should have capnography. It doesn't matter whether you saw it go through the cords or not. If you have a flatline capnograph and no chest rise or fall, your tube is not good. So, you always want to evaluate that constantly. Breathing problems, tension of the thorax, a sucking chest wound is where you have, is also known as an open chest wound, where you have, let's say, a gunshot wound to the chest cavity, and you have air coming in both when they breathe through their mouth and also through the hole in their chest. The treatment for that is by using occlusive dressing or a Vaseline gauze dressing taped on 3 sides. A flail chest is where you have 2 or more ribs broken in 2 or more places. Some books say 1 or more ribs, but generally the 2 or more ribs broken in 2 or more places, where you get paradoxical movement, whereas the flail segment moves opposite direction of the chest cavity. Diaphragmatic injury is when you have the diaphragm separates the pleural space or the thoracic cavity from the abdominal cavity. So any type of low thoracic injury, we need to suspect an abdominal injury with penetrating trauma. High spinal cord injury, high cervical fractures, you sever your spinal cord, you'll cease to breathe. You cease to breathe, your heart will cease to work after time. Carbon monoxide inhalation. Remember, carbon monoxide binds to hemoglobin with the same affinity as oxygen. So pulse oximetry will give you a false reading of 100% on a profoundly hypoxic patient. Smoke inhalation, aspiration. Has this person been aspirating blood? Has they aspirated vomitus? Near drowning. Okay. Near drowning is whenever anybody is in the process of drowning. Once someone has died from a drowning, then they have drowned. So that's the difference between near drowning and a drowning. Central nervous system depressions from drug, alcohol. Check pupils. If they're pinpointed, you suspect narcotic overdose. Narcan is very much appropriate. However, without adequate CPR, Narcan will not work. You can't circulate a drug if there's no pump working. Also, you want to check glucose as well for if this has been caused by a long-standing diabetic issue. Apnea secondary electric shock or lightning strike is another one. Electric shocks, lightning strikes. With enough electricity, you could break bones and sever your spinal cord. Remember, our body works on electricity, and our central nervous system controls our peripheral nervous system. So our central is our brain and spinal cord, and our peripheral is everything else. So the brain is our computer. It tells the body what it wants to do by sending messages from the central nervous system to the peripheral, and then the peripheral returning messages back to the brain through the central. Circulatory problems, hemorrhagic shock, okay, or like they coin it empty heart syndrome. So there's not enough blood or not enough blood with oxygen carrying capacity. Tension of the thorax. Tension of the thorax, you have more air on the outside of the lung than on the inside, causing increased pressure in the thoracic cavity, thus squeezing the heart and diminishing cardiac output. Pericardial tamponade is the same difference. The sacral heart fills with blood and squeezes the heart in a submission essentially, and you get drop cardiac output. Myocardial contusion. Myocardial contusion is a bruise of the heart, which can imitate a myocardial infarction and can cause EKG changes. And you tend to see that from blunt chest trauma. So that's always one thing in consideration when someone has chest pain after a chest trauma, a blunt chest trauma. Don't assume that. So, well, yeah, you had your seatbelt on, so you have a seatbelt abrasion. Therefore, your chest pain must be caused from chest wall pain and not myocardial pain. So never just try to minimize what you suspect. Always suspect the worst and hope for the best. Acute myocardial infarction, people have heart attacks when they're driving themselves to the hospital. So, and cardiac arrest, secondary electric shock. Hypovolemic, blood loss could be external, internal, or both. External hemorrhage can be controlled through lots of different means. Arterial bleed tends to spurt. Venous bleed tends to pour out. When you have someone who has massive extremity bleeding, proper treatment is to apply a tourniquet high and tight, um, not to put it over a bony structure, but to cinch it down tight and then use the windlass until you lose the peripheral pulse, um, lose the pulse distal to the injury, and bleeding should have stopped. It is possible if they're still bleeding with that, you can apply a second tourniquet just above the first one. Um, you can also, depending on what type of bleeding you have, you can control it with direct pressure and also pressure dressings as well. Massive external bleeding can cause all types of issues. Um, it can be hard to be controlled with amputations, depending on where it's at. If you have an amputated limb, generally if you have parts above it, on the extremity, you can apply a tourniquet. If you have what they call junctional wounds, such as in the groin, in the armpit, things like that, those are very hard to compress and put pressure on and very hard to control. There are some junctional tourniquets on the market, and the military has deployed several of these. However, due to cost and also the availability of valid studies upon the use of these in the pre-hospital setting, limit their use. Prompt IV fluids can give a chance of salvaging on these cardiac arrest patients, but remember, crystalloids and colloids, crystalloids are crystal clear. They'll fill the vascular space, but they contain no oxygen carrying capacity. Therefore, getting a patient someplace that can get them blood on board is what is needed. Massive internal bleeding. Remember, solid organs bleed. You can lose all your blood volume in your abdomen. You can lose all your blood volume in your retroperitoneal space where your kidneys are. You could bleed to death in your pelvis, and you could bleed to death from bilateral femur fractures. So, and I guess I should have told you what TCPA is. It's traumatic cardiopulmonary arrest. So, when you have patients from severe hemorrhage, they're usually fatal. So, most victims of traumatic cardiac arrest tend to be young people that feel like they're invincible. They have no pre-existing cardiac disease. Do your scene signs up. Make sure your scene is safe. All hazards are removed. Carefully record observations. Does the injury match the mechanism? So is this a crime scene type thing? You want to differentiate from medical cardiac arrest. So you can give, 2 to 4 liters normal saline rapid infusion. However, I would be cognizant on dumping 4 liters and generally safe to sticking to 20 per kilo, 20 cc's or 20 milliliters per kilo, and reevaluating titrated to their blood pressure and also, of course, the most importantly, to their lung sounds. If their lung sounds are getting wet, it's indicative of pulmonary edema, and you don't want to keep dumping fluid in these people. Special groups, isolated head injury. It's hard to determine that in the field. Obviously, an open head injury is pretty easy if you have brain hanging out. But a closed head injury where we tend to see Cushing's reflex, which is indicative of herniation syndrome, where we see hypertension, bradycardia, and irregular respirations, normally Cheyne-Stokes or Biot's respirations. A massive blunt injury. If they have a massive blunt injury, something, very heavy was dropped under them, they're found asystolic. These are conditions, that may be non-viable. Children do respond well, even in trauma, depending on the nature of their injury. But they do need to be aggressively treated, and you need to remember with children, of their airway and cardio. Children tend to have airway issues leading to cardiac, but in case of trauma, the airway is very important as well as maintaining cardiovascular status. You want to follow PALS guidelines, your Pediatric Advanced Life Support, which you guys will have upon completion of your course if you haven't had it already. Electrocution, they may have severe muscle spasm. They may have muscle paralysis within the respiratory system. They may have been thrown a great distance. Sometimes because of the muscle spasm, they're still holding on to the electrical source. You should never try to use anything that dislodge someone or knock someone off electrical source, because you will end up the secondary victim and also be a co-electrocution, and not all things are worth sharing. So, the the electrical source should be shut off by someone who's trained to do so, and the patient should be removed from the source once the scene is safe. If the patient's been thrown down or fallen a great distance, spinal precautions are needed. Lightning strike is the same way. Remember, our bodies are made of water, and our brain and heart runs off electricity as well as our nervous system. So lightning or electricity will follow the path of least resistance. Pregnant traumatic arrest. Treatment priorities are the same. Remember, survivability of the mother is directly dependent, or survivability of the fetus is directly dependent on survivability of the mother. Even though there's been urban legends of emergency pre-hospital C-sections done, and some of them have been done in the field in some areas, the outcomes tend to be poor for the mother and the fetus in the pre-hospital setting. So defibrillation settings are exact same. Drug doses are same. Fluid volume needed does increase. Remember, your pregnant females will exhibit signs of shock later, just due to increase of blood volumes in the later stage of pregnancy. If mother is unsalvageable, you'll maintain CPR. Remember, survivability of fetus is directly dependent on survivability of the mother. Notify the hospital of a possibility of a C-section. That's not notify the hospital possibility of you doing one, but it's notify the hospital so they can have adequate staff on hand to receive that patient to be able to perform this. Considerations of management: airway. Also, make sure the airway is open. Okay, make sure it doesn't have any obstructions. Endotracheal intubation can be very difficult in trauma, especially with C-spine precautions. So in many cases, a blind insertion airway device, such as the iGel airway, are more appropriate. However, if you do use ET tube, remember I was talking about peri-intubation hypoxia. So don't lead to a further oxygenation insult from performing a procedure. So look at the Mallampati score. Remember that immobilizing patients in the inline position are very, very difficult. So, your goal is to not drop a tube. Your goal is to secure an airway so you can provide an open airway and facilitate air exchange and ultimately gas exchange and improve oxygenation and cardiovascular condition. Ventilation, remember, ventilation means move air in and out. So positive pressure ventilation, it does reduce venous return. So we want to really be cognizant as to how hard we squeeze that bag and the cardiac output, because you don't want to increase tidal volume at the risk of cardiac output. So remember, overventilation, so you don't want to ventilate more than generally 8 a minute with a 750 cc tidal volume for adult. And that's even a little bit high because the average tidal volume for most adults is 450 to 500. Generally, it's averaged on ideal body weight when you're looking at ventilator management, but 450, 500 is a generally good rule of thumb. When you fully squeeze an adult bag valve mask, it gives you 1,000 cc tidal volume. So you want generally half or just a little bit greater than half a squeeze when we ventilate an adult. Capnography, remember, measures perfusion, very valuable tool in your traumatic patient. Okay. So, summary, remember, traumatic arrest survival is very rare. Pre-hospital guidelines, always consider, err on the side of caution. Always think, is this something that can be reversible? Is it tension in the thorax? Something can be treated right away. Is this an arterial wound, arterial bleed that can be fixed right away with a tourniquet? So there's a lot of things that could do that. One other thing you need to think about too, not necessarily the traumatic arrest, because most flight programs or air medical programs won't fly someone with CPR going on just due to the effectiveness of it, but some flight services do carry the auto pulse or the Lucas device and will fly a patient cardiac arrest, so you should know the limitations of the air medical services that serve your area. So this concludes the summary of traumatic cardiac arrest. Remember, keep studying those rhythms, keep studying your drugs, and remember, medications generally don't fix traumatic conditions. It can reduce things like VFib threshold by giving ventricular antidysrhythmic, like in the case of an electrocution, but generally fixing the cause of trauma or fixing the life-threatening event is more what they need. The presenting rhythm of these patients tend to be either tachycardic PEA, such as a sinus tach, because if they don't have any heart issues and they just lost their volume, you'll see things like that. So this concludes the lecture on traumatic cardiopulmonary arrest. It'll be posted. This will be posted on YouTube and also on Canvas. If you have any questions, feel free to email me, call me. You all know my cell number, or text me, and I'll be glad to get back with you right away.